Hello, everyone. Good afternoon, and welcome to episode 3 of our webinar series titled Do Health Systems Deliver? I'm Dr. Sarah Naif, and I'm honored to guide today's session. Thank you all for joining us. And as we continue our journey exploring how patient reported data can inform and transform healthcare systems, in our first 2 episodes of the webinar series, we explored the foundations of the OECD's Paris Initiative and the critical roles of PROMs and PREMs in capturing what really matters to patients. Today, we shift gears slightly to look beyond those measures and focus on something equally essential, healthcare capabilities. In today's session, Beyond PROMs and PREMs, Understanding Care Capabilities, we'll delve into what really makes health systems operationally strong, from digital tools to care coordination mechanisms, and how these capabilities are measured in the Paris survey. We're joined by an esteemed expert who brings deep experience from the Saudi health system, Dr. Turki Al-Atabi from the Ministry of Health. Dr. Turkiya is a consultant family medicine and the general supervisor of clinical excellence at the General Directorate of Primary Healthcare Affairs at the Deputyship of Population Health at the Ministry of Health. She's also a member of the Scientific Committee of Family Medicine at the Saudi Commission for Health Specialties. And over the next hour, we'll unpack how these care capabilities influence outcomes and support delivery for patients with chronic diseases and shape national strategies. We also want this to be an interactive session, so please feel free to submit your questions throughout, and we'll address as many as we can during the Q&A session at the end. Before we jump into today's session, I'd like to take a moment to remind you with the broader Do Health Systems Deliver webinar series. The series brings together timely insights from the OECD's Patient-Reported Indicators Survey, or PARIS, to reflect on how well our health systems are meeting the needs of patients, especially those with chronic conditions. Through patient-reported data, we aim to paint a clear picture of healthcare performance from the perspective that matters the most of patients. In our first webinar, we introduced the PARIS Initiative and reviewed some initial findings from Saudi Arabia's participation. We looked at the makeup of our patient population, chronic condition trends, and provider profiles. In episode 2, a couple of weeks ago, we shifted our focus to the tools that gave patients a voice, PROMs and PREMs. And today's episode will connect these patient-reported outcomes to health system capabilities, helping us understand where improvements can be made. And then finally, next week, we'll look outward, comparing Saudi Arabia's data to global benchmarks and learning from other countries. Together, these conversations are about more than data. They're about driving real change. We're excited to have you with us as we continue the journey. So let's get started. So what we have planned for today's session, I'll just start with a quick recap of episodes 1 and 2, and then we'll shift focus to today's main topic, care capabilities, what they are, how we measure them, and why they matter in delivering value-based care. This episode is going beyond patient's voice and understanding the infrastructure and processes that enable high-quality care. PROMs and PREMs, they give us the what from patient perspective, but the capabilities help us understand the how from a system perspective. And all of this work is really rooted in the OECD's Paris Initiative, which, as you see, is not just a measurement framework. It's a roadmap to more responsive care for patients with chronic diseases. So in our first episode, we introduced the OECD's Paris survey, its significance in measuring what matters to patients, and to provide more person-centered care. We explored the goals of the Paris project and how it supported value-based healthcare by shifting the focus from clinical activities to PROMs and PREMs. And Paris will help us achieve the goal of providing person-centered care by international benchmarking. Since this is an international survey with the participation of 20 countries, this will help us in assessing how Saudi Arabia is doing among these countries and collecting comparable data from different health systems on outcome measurement. And this really helps policymakers understand how their health systems are performing and where improvements and efficiencies can be made. We also shared early insights from Saudi Arabia's implementation of the Paris survey, focusing on these main themes measured, including practice type and location, access to care, the skill mix of providers, how they're reimbursed, what the digital information system looks like, care coordination practices, use of care plans, and self-management support. A bit about the results. So they did reveal that there was a very high prevalence of chronic disease, especially among the young adults, and emerging trends in multimorbidity, which is really worrisome due to the lifestyle behaviors and the care they report. For provider characteristics, they revealed the structure of primary care delivery, the current service models, and the need to strengthen coordination. When we looked at healthcare trends, they did point to the fragmented nature of care delivery and the central role of primary healthcare in addressing long-term health challenges. When we looked at outcome measurement, they emphasized the need for standardization, validation, and national adoption of patient-reported measures across healthcare sectors. And then we concluded by reflecting why this matters for the stakeholders. Looking at the prevalence of chronic diseases, 70% of respondents overall had a chronic disease, which is an extremely high percentage. 82% of patients aged 45 and older and 56% of younger patients had a chronic disease. Most common reported conditions were arthritis or ongoing problem with back and joints in 30% of the patients. High blood pressure, diabetes, and breathing conditions were also high. And then mental health problems or mental health conditions, including depression and anxiety, were existent in 8% of the population. 20% of respondents had more than one chronic condition, which is very worrisome. We then took a look at the PROMs and PREMs, and this slide summarizes the key domains measured by PROMs and PREMs, which are essential in understanding healthcare from a patient's perspective. They go beyond clinical outcomes to capture how patients feel, their function, and experience of care. For PROMs, we measured physical health, which assesses limitations in physical activities such as walking, lifting, or helping assess the impact of illness on day-to-day life. Mental health captures emotional well-being and anxiety and depression levels. We also looked at social functioning, which explores how health conditions impact a person's ability to participate in work, family, and social life. Well-being reflects the overall life satisfaction. And then general health offers a broad view of how patients perceive their overall health status. We also looked at PREMs, patient-reported experience measures. We looked at confidence to self-manage. So do patients feel empowered with the knowledge and skills to manage their condition? And then we looked at care coordination, which assesses whether care is seamless across providers, which is really critical for patients with complex chronic conditions. We looked at person-centric care, person centricity, which focuses on whether care aligns with the individual needs, preferences, and values. We looked at experienced quality, so how patients rate the care they receive and what's respectful and timely and so on. And finally, we assessed the trust in the healthcare system, which measures confidence in the system's fairness, accessibility, and ability to meet their needs. So some results of PROMs and PREMs for patients with and without chronic diseases. This is the percent of patients with positive outcomes, so the higher the better. And what we note from the beginning is that patients with chronic diseases have worse outcomes and worse experiences across all of the PROMs and PREMs. So there's a distinct and direct link with chronic diseases and poor outcome. Another really notable result is the very low rate of experienced care coordination. This is also low in Saudi Arabia compared to other countries, which is highlighted in the international flagship report that's been published. And we can also see some notable trends. So although our mental health was pretty high, well-being is low, attributing to further issues in psychological health attributed to chronic diseases. Self-management is also low, and also when we compare it to other countries, it's lower than the average. This maybe highlights the low health literacy the population has to manage their health and well-being. So these were some results. But in today's session, we're zooming in on what we call care capabilities. These are kind of the operational building blocks that support how care is delivered, especially for patients with chronic conditions. These capabilities are captured in the OECD PAIRS survey and help us understand not just what outcomes patients report, but how the system is enabling or blocking those outcomes. So some of what's measured: communication, which refers to how well patients are able to communicate with their care providers, how they're being heard, understood, and involved. It also measures shared decision-making, which is vital. And our patients, for example, are patients participating in their care planning, or is it still mostly top-down? Support for health and care, which includes emotional, informational, and practical support that patients receive. Type and number of providers, so the composition of care, of the care team, which really matters to the patient. Is there a multidisciplinary team? Are there enough providers for timely access, and so on? The digital information system, from electronic health records to clinical decision support, digital tools, how they document care, how they're accessed and coordinated, and health education. So are patients given information about their condition, how they management, and are they empowered to use this information? Organization of healthcare. So how is the system structured? Is it fragmented? Is it more integrated? And this really impacts the referral process and so on. Care coordination, which is again crucial for patients with multiple chronic diseases, and personalized care plans, which help track progress, anticipate needs, and keep the patients aligned with their health goals. Self-management support, so are patients being given the tools and encouragement to manage their own health? Access to care, this includes a range of attributes, so physical access, affordability, timeliness, and so on. And finally, online services, so digital front tools from appointment booking, video visits, and so on. These indicators help us in understanding how well equipped a health system is to support chronic disease care, not just from the clinical side, but operationally and holistically. During this session, we will hear from our guest about how these capabilities are being developed, measured, and used for implementation and improvement across Saudi Arabia's primary healthcare centers. So without further ado, I welcome our guest for today's session, Dr. Turkiya Al-Atiebi. I welcome you to our webinar series, and thank you for joining us and giving us the time to participate. I wanted to start with an introduction and start talking about primary care. So Dr. Turkiya, can you start by telling us about some of the key primary care improvement projects at the Ministry of Health, for example, like the team-based care initiative or others, and how they're supporting more coordinated and patient-centered care?
Well, thank you very much, Sarah. Thank you for your invitation. I'm very much pleased to be participating in this very recognized webinar, and I welcome all our guests in this webinar, and I hope that it will be like an informative and very insightful session. So to start with your question, actually there has been a lot of initiatives and projects in the last 3 years. And basically, to start with the team-based care approach that you have asked about in your question. Actually, the team-based care approach is a new innovative way of it is not like a new care or a new services. It is a model. Primary healthcare has been always the gatekeepers for health for the community. But when we thought that, sometimes there are elements that is very necessary to maintain health for individuals in the community and their families, we wanted to assure that there is a continuity of care and there is like an accountability. We wanted to create a sense of accountability on healthcare providers at primary healthcare, and this is through the team-based care. So the team-based care approach is really a new model of delivering healthcare services at primary healthcare. It is a matter of a mind shift rather than new services, so that the healthcare providers will be fully responsible and accountable to a list of people and their families and individuals under their name. So this will assure and help in the promotion of health, the continuity of care, the care for the chronic diseases, and the necessary screening and essential immunization for the community, rather than waiting for the community or the individuals to seek for health. For healthcare. So it is an approach that will help to change the health seeking, the system. Actually, it will change the healthcare system from being totally person driven or individual driven, based on their needs and based on their requirements, to a system that is to be like healthcare will be system driven, where it will outreach and identify those who are in need of any healthcare services. So there will be like a team formulated and created within the primary health care. For example, Team A and Team B. Each of these teams will have their registered and identified beneficiaries. And, actually, it was through process, and it is a huge process, actually. The empanelment, the assignment of the individuals to these primary health cares, the distribution of the teams within the primary health cares, and we have faced now like major difficulties, and we have overcome some, and some are still to be, managed and being solved right now. So, but the concept mainly is that we wanted to have like an insight on who are being treated and who are being approached and what has happened to their health. So that we want to capture all the patient physicians encounter and see exactly how it will contribute to our population health, as also one of our like 2030 vision goals. This is a concept. The other thing that actually I think it is one of the major projects or initiatives in the last few years is the major digital transformation that has happened. We're talking about like virtual care, virtual clinics inside the primary health care. We're talking about digital platforms that allows and facilitate the two-way communication between the individuals and the healthcare system, whether it is through Sahati app, whether it is through Anat app. So now all the individuals that are registered within the team, they can initiate a conversation with their care providers registered with them through Anat app and through a chat, actually. We call it a chat, but it is through Anat app. So this is like a two-way communication to enable the communication and to enable to ask, the easily, answer the question. And also we have enabled for the teams to do a broadcast. So we have used that in certain campaigns at a year. For example, the flu vaccine campaign starting from, late autumn. So it will be distributed to all the beneficiaries registered to remind them that they need to have this like flu shot to protect them through the winter. So this is the second thing, like within the digital transformation concept is also the clinical pathways. We have more than 2,200 centers around the kingdom. So standardization of care, and I know that you have mentioned that earlier in your introduction, Sarah, that it is pretty much needed when we talk about provision of care for chronic diseases, especially around the kingdom. So clinical pathways has helped to create the minimum set of orders that are needed to guide the physician through the consultation and to remind them of the necessary interaction or action, or even orders. So it will be not left totally for the physician. When we say more than 2,100 centers, we will have definitely disparities in care provision capabilities. So it's not any completely like a smart pathway, but at least for the minimum orders. For example, for the example of the care of the pregnant ladies are really important categories of visitors to the primary health care. So all the order set or the necessary action that has need to be done for those pregnant ladies in reference to the الجواز الصحي للأم or the health maternal passport is transformed completely to a digital inside the health information system in our primary health care, and it will calculate the gestational age specifically, and it will give an order set needed for those ladies, whether it is a shot or a vitamins or even a referral for ultrasound. So these are examples of the things that has been done as initiatives in the primary health care lately.
That's really great. I mean, you spoke a bit about digital, and I'll use that as a segue to my next question. We know that MOH has made strong strides in digital health, from, you mentioned, electronic medical records to booking and follow-up systems. As this digital foundation matures, where do you think we can push to further improve outcomes, measuring outcomes through these digital tools?
Sure. Actually, maybe I would tackle two dimensions that are needed to be, supported and helped by the advanced technology and digital transformation. So basically, we have covered the standardization of care. Basically, we have covered the element of communication and the access to care through the appointment apps and etc. I believe there are necessary moves have to be done, and we have to work on certain things. The things that digitally need to be done right now to improve the outcomes is the completing the cycle or completing the loop. We have the primary health care that there are a lot of services to be completed at the hospital site, or whether secondary or tertiary. We believe, and we are currently working on making an interconnected system where the access to the health records of the individuals, regardless where do they go, is really necessary. Sometimes a piece of information is really necessary even for life saving. So currently we're working on the unified health records, or even the NAFIS, maybe you heard about it, to be the cloud that contains the necessary information that will be accessible by in a controlled way by the healthcare professionals. So we believe that completing all the information and the loops, and because in primary healthcare we refer for breast cancer screening and colon cancer screening, but we do have difficulties in getting the results back. So I believe having a unified health record, having a cloud that would provide the necessary information for related to the individuals is really important. Other thing where we think it will improve the outcome is the self-management and self-support. We believe that we have to work on, in projects, and currently we're working on a project which is a technical project, is called the Digital Twin, where the mobile apps and phones are reflecting or creating a health profile. It will tell you what is your weight, how much do you walk a day, what are your diets based on what you even it can track your orders in the food delivery apps. Mm-hmm. So we wanted to create a health profile from all the necessary the available information in your mobile phone, so it can label you and what health status you are. And not only that, and we also wanted to have this a digital twin, with the help of the digital twin technology, to even monitor and follow the chronic disease. reminders of appointments, reminders of necessary screenings, reminders of the medication and the compliance to medication, and assessing also the compliance of medication. So it is actually wide what we can do digitally to improve the outcomes. And certainly it will take time, but I think right now, from our perspective, primary healthcare, the priority things to do is to provide all the information needed to have an access to that through the interconnected systems or unified health records, and also to help people to own their health through information gathered from their mobile apps that can help them to give a few, insight on their health profile.
That's great. That's really a great tool to look at integrating care, because we really don't think of it that way. I mean, we highlighted this as one of the results of Paris, but care coordination, it often really comes up as a challenge, but also we can look at it as an opportunity, especially when managing chronic conditions. And what you mentioned is part of it, an aspect of it. But from your experience at the Ministry of Health, what care coordination models have worked best? Are you seeing more success through dedicated roles like care coordinators or through digital enablers, as you mentioned? Is there a more formal role for nurses or allied professionals in care coordination under the new primary care model?
Yes, actually, the care coordination concept is really important and has arisen when the model of care even concept has been established. From our experience, what has been done in the field of care coordination, not to my surprise, the digital implementation of the care coordination was not the hardest, actually. We have been able to create like a page or a platform in our health system, health information system in the primary health care that is meant for the case coordinator. And it is, for example, you can just name the breast cancer coordination. The breast cancer screening case coordinator page, and it would list for you in a certain team all the ladies that are entitled for breast cancer, and it will identify for you whom has been referred and who wasn't, and if they were referred, is there a result or not. So the case coordinator would not need to go through all the records, and he will use this page that summarizes the status of breast cancer screening for the eligible ladies. So this has been implemented. But we have, challenges. I'll be very honest that with the manpower or the human resources. So that's why we have initiated a collaboration with the Saudi Health Council for the healthcare specialties. Actually, till today, there's no, definite role or like a job description for case coordinator. It is a new concept. So it's basically covered by sometimes nurses or even physicians or even administrative personnel. So what we want to do is we want to, optimize this role to be very recognized and respected and, cherished, actually. So we wanted to have this job as a real job, as a part of the team, standalone. It's not to be covered, temporarily by nurses or other healthcare professionals. So we have initiated this with the healthcare specialties, Health Council of Healthcare Specialties, and we hope that it will be like soon a recognized standalone job. So technically, it's not difficult. Maybe the persistence and the continuous work as a case coordinator should be supported by a field of, human resources to be like a permanent job.
Yeah. We hope that's what's going to happen. It would alleviate some pressure on primary care physicians and also contribute to the care coordination. I want to shift gears maybe to focus on the Paris project, and the capabilities that were measured in the Paris survey. Some of the capabilities, such as time spent with patients, use of clinical decision tools, and others, were there some findings from primary care centers that stood out for you? And are there any gaps or strengths that were very surprising from the Paris results?
Yes, definitely. Actually, it is not really surprising, as it is, it is a gap and a very recognized obstacle. Actually, the time spent is really necessary. For example, the chronic disease care, we would like that the chronic disease patient to have the enough time to discuss their care plans with their physician and to have the full understanding of their condition and to own it, as we said earlier. Actually, these obstacles can be overcome by a lot of, intervention. I believe maybe I will highlight the things that can improve these outcomes or these numbers or the results of the Paris. For example, the utilization and the implementation of supportive health services. As an MOH, primary health care, the care team is basically consists of the physician, the nurse, and sometimes the health educators. I believe if we have like a practice nurse, a midwife, a dietitian, a diabetic educator would really contribute to the overall positive outcomes of healthcare. Chronic disease patients. So, and this is basically linked to the first item, which is the time spent. We believe that it is not necessarily like the physician. If we have, we know not all of the visitors to the primary care are all, chronic disease. We have the walk-in, and we have the other those who attend for other reasons. And actually, the burden on the primary health care in the primary health care centers is huge. So we can understand that the time spent is not really optimal, but we can overcome that by creating, let us think outside the box and do other things. If we we thought of utilizing or capitalizing the virtual hospital. Why not using the virtual supportive healthcare services at the virtual hospital? The social worker, psychologist, dietitian, diabetic educator, not necessarily they need to be, present in the primary health care, but we can maximize and intensify the effect of this consultation time by providing time and allocating a time for all the other necessary information and intervention to be done by people or health professionals other than the physicians. So this is one. And regarding using the clinical tools, actually, I believe, to be fair, that we have, some advancement at this moment for the clinical decisive tools. As I said before, it's not like really a smart system, but at least it would help. And it is a continuous improvement project. Actually, we are trying to the clinical decisive support system to be optimal. And it helps in standardization of care. It helps in creating a data field that is necessary to create certain dashboards and extract certain clinical and operational KPIs. So this is basically still, of course, it needs continuous improvement. But I believe that we've reached to a good states right now, but definitely can be improved and optimized more.
Can you, these are really great advancements and improvements, but can you tell us some of the behind the scenes? So some of the barriers or challenges you faced when trying to operationalize care capabilities across primary care centers?
Okay, so basically, if you will ask me, what do you want to do? I think continuity of care is really important. I think one of the major things that you want to do is to assure that the patient would come and see their physician, the same physician or the same team all the time, for better understanding and to minimize the time needed to be reintroduced to the physician again. So this is one of the major operational obstacles that is the population, the individuals and their families would go to different primary health cares. Even after implementing the concept of team-based care, they're still allowed, to go to healthcare centers and receive healthcare services from anywhere. So I believe that continuity of care, implementing the model fully is really important. Sticking to the same team, of course, with the full, approval of the patient the beneficiary and their families. So these are one of the really important things to do, is the continuity of care. The other thing is, we are actually transforming now. We are in the middle of the health transformation. So we are moving toward the concept of population health, and we need to stop the classical way of providing healthcare. As I mentioned earlier, we need to outreach people. One of the major obstacles that we do have, a huge percentage who are unknown to our healthcare system. So outreach, identifying people, doing the proper screening, checking their immunization status, protect the public health of the country. This is one of the new dimension that has been that we have entered lately. But I think there's a huge work to do. Primary care, with the classical way of primary care, was serving those who can come to us. But I think with all the things that I've mentioned, we need, with all the digital transformation, with all the models, the model of care, the TBC care, the TBC model, the clinical pathways, the standardization of care, the apps, and everything, it must contribute to the ability to identify people at risk at their homes, or even to diagnose disease earlier, or to prevent it or screen it earlier. So the concept of outreach, the concept of protecting the health of the public, is a really important one, is really a major one, and it is a dimension that we are going through right now, and we need to provide all the necessary capabilities, infrastructure, digital, human resources to achieve.
That's really interesting. And it's really exciting to hear how PROMs and PREMs, while they give patients voice, these capabilities show us if the system is ready to meet these needs. And as we begin to align these two, it's creating a fuller picture. You touched on this a bit, Dr. Turkiya, but the model of care and the clinical transformation programs, they are central to the health transformation. How do you see those initiatives translate into more population health-oriented strategies in the primary care setting?
Sure. Actually, the concept of model of care is really important. One of the major things that it led to is the work on integration between the different level of healthcare systems. A model of care does mean what I'm about to say. It is the care of the individual from their home, through the primary health care, through the secondary or tertiary care, back to the primary health care, back to the individual at his home. And you can imagine what this pathway would require. It requires the full understanding. It requires outreach. It requires identification. It requires enrollment of people. For example, let us say that we are talking about the maternal pathway in the model of care. Maternal pathway has led to the maternal pathway in the model of care has led to more than actually stakeholders to sit together and to see the full picture and to do the improvement needed in order to achieve the final results, which is decreasing maternal mortality, which is one of the major major indicators for the advancement and for the nation. So it actually, the model of care have helped us in the last few years to identify the gaps fully, and to try to find, for example, another example is the depression pathway, or the primary mental health pathway. When we have implemented this pathway in the primary health care, we thought that we can start the screening earlier in Sahati for the individuals within their home. It is about PHQ2 and GAT2 question. within their home. They can answer, and the score can be calculated. They can receive a message, and they can go to the primary health care based on that message. What we have done, and this is a concept that we want to implement. Currently, it starts within the primary health care, but we want to do it earlier, at an earlier step at the home. The other thing that we have found and led to a strategic or a policy making is the care for the suicidal thoughts patients. So we thought that, okay, we found that we have more than 2,200 primary health care centers. Come on, somebody, we have captured the data that they have suicidal thoughts. So that led us to communicate with the stakeholders in the mental health and the Ministry of Health. So we wanted to do a unified suicidal pathway. So everybody at every primary healthcare center should know how to deal and to direct a patient who have suicidal thoughts. We know that at primary care within hospital, it is very structured and well organized. In like the primary healthcare in the defense, or then the Ministry of Interior, or even the academic hospitals. But in primary healthcare, in more than 2,000 centers, there's no unified pathway for that. So from the model of care mental pathway, we have identified that, okay, this is strategically need to be written and designed very well. So these are the examples.
That's great that you're thinking of these pathways, especially when looking at mental health, because when we noticed, and we discussed this a few times, mental health was performing very differently on the data for Paris. So we performed very well on mental health, but we performed much less better when we're looking at well-being. And mental health is a taboo, and we really need to bring the attention towards mental health. I wanted to end with a few questions about policy making and changing policy. And we often say that measurement is really only powerful when it drives action. From your perspective, Dr. Turkiya, how can health systems translate findings from indicators like care coordination, the use of guidelines, digital readiness into these meaningful service improvements on the ground?
Yes, definitely, Sarah. Actually, again, we're dealing with public health indicators. We are entitled to implement public health agenda. One of the examples that we wanted to check from the data. First of all, let me say that you cannot operate, you cannot change unless you have data. So one of the major advancement that happens in the last few years is that we are able to have a look on clinical indicators. It was really, I know the Ministry of Health at 2017, and I know it's now. There's a huge difference, instead of going through the records and the manual collection, and that is subjected to, bias and, error and fabrication and everything. So what we wanted to do is that we will have to have an insight. We have to have dashboards to put all the major public health indicators so we can. One of the example is that we wanted to test the vaccination of pregnant ladies by Tdap, which is the diphtheria and pertussis vaccine. We have linked between an increasing numbers of pertussis among newborns, and we looked back at were they covered by this vaccine or not. So that led us to making like an announcement or a memo that please, all the ladies at the 27-week till before delivery, they need to have this vaccine. So this is the beauty of having clinical indicators, clinical data, and relating these data and analyzing it with major changes or trends at health. So we can make, by this, you can make the important strategic moves or policy. So this is one of the examples. One of the other things is that the screening for autism. We have found that there is like a lot of cases increasing in the last few years for autism, spectrum of autism, and there was no much attention really for that in the primary healthcare. We have and there's like a mandate. Actually, it is a real important mandate to screen and to identify those children at earlier, because it is really critical and golden period of time at their life, where if you pass it, maybe the recovery will be like very difficult. So we wanted to implement the clinical pathways inside the health information system that would recognize all the children from the 18 months and above, in order to apply for them the standard tool for screening of autism, and highlight that and capture that in the system and in the record. So there are lots of examples, but you cannot formulate a policy or make a strategy unless you have findings, and you have, after you analyze the findings and link it to current trends.
Yeah. That's really the heart of it, and moving from insights to impact. It's really one thing to collect capability data, but another is to weave it into planning and service design and accountability structures. I want to take a few questions from the audience before we close today's very insightful session. We have a question about digital tools, and the question for you, Dr. Turkiya, has the digital revolution seen in primary care improved user confidence in the system, and how are we measuring this?
Yes, definitely. Actually, to be honest, there was very variable, feedback and insight regarding the current use of the health technologies, or even the pathways or the system. We find, because we do have like frequent surveys that ask the users, the end users, about these technologies, and it was variable. It depends on the on different factors. Actually, we found that more younger generation, that they have adopted it very quickly, and they have thought of it as an advancement. Also, it is affected by the factor of flow and time. So there are a lot of factors, but meanwhile, the overall is really satisfying. It has helped a lot, and what we are trying to do is also to do the automatic filling of some fields. We want the healthcare providers at the primary healthcare center we want the typing and the filling time to be minimized as much as we can, in order to utilize their time to serve their patient. So the auto-filling, and actually, as I said before, it is a process of improvement. Like, when we released the version 1 of this health information system, there's a version 2, there's a continuous improvement, there's ups and downs, actually. But the overall, and today, there's like an overall satisfying results. We measure it by the we call it the voice of the users through the operating company of our healthcare system. And this is regarding the end users, the doctors and the nurses at the primary healthcare.
That's really encouraging. I can say a few words about the Paris project, because we measured trust in the healthcare system as one of the PREMs. And really, Saudi Arabia, even when you look at the flagship report, it's really outperforming other countries in terms of trust in the healthcare system. And this is also high when we looked at the national data. It's high across all sectors. So Ministry of Health, OGS, and the private sector. The trust in the healthcare system is high. And of course, it varies for patients with chronic diseases and patients without chronic diseases, or per age group. But it was really encouraging seeing the trust in the healthcare system very high. It's also in line with the trust in government. So people are confident that when they need care, they can receive it. It's free of charge, and etc. So this is very encouraging, and I think this can be attributed to the advancements you've made within the primary healthcare settings. Another question was, what are some of the significant gaps in coverage of key population level screening and preventive services across the country? And are there any insights on user-reported quality ratings of primary care services?
Gaps in screening, you mean? Yes.
Yeah.
Yes, definitely. Actually, as I said before, the major gap in screening that we have found is getting the results back. Definitely. Some of the screening will be taking place in other institutions rather than the primary healthcare. When we're talking about colonoscopy, when we're talking about, breast cancer screening, sometimes the osteoporosis screening, and etc. Definitely, there are screening that is very easily implemented, and the results can be taken right away in the primary healthcare center. For example, the screening of obesity, the blood pressure, and hypertension, and this stuff. So the major, actually, we're having like a major difficulties in the screening of the breast cancer. It is a mammogram taking place in the hospitals. So that's why we are taking like a workaround solution in order to get the results, whether it's by like case coordinators, or it is by getting like a report from the hospital itself by direct means. So this was the major things. The other thing that I have mentioned earlier is that we cannot say that we are doing a full screening unless we really outreach people and identify those at risk who need to be screened. And this is what we want to do. We want to from the digital tools and the digital twin concept and from their health, the mobile apps, we want to identify people who are at risk and get them a message to nudge them to go to the primary health care to undergo screening. So we have the gap, the challenge of we're still screening those who comes to us. We need to identify those who are at risk and need the screening when they are at their home and nudge them to come to us.
I think there's one more question about PROMs and PREMs, and I can take this question. Can you elaborate more on the results of mental health versus well-being? Sure. So when we looked at the flagship report, the international comparison, we noticed that Saudi Arabia is performing much higher than other patients on the mental health outcome. Even patients with chronic diseases are outperforming patients without chronic diseases in other countries. Even patients with multiple chronic conditions are outperforming patients without chronic disease in other countries. So we were really doing a really great job in mental health outcomes. We were kind of an outlier. But then when looking at the well-being, which is a composition of mental health and physical health, that's when we see the results more leaning towards the average. So we took a deeper dive into the results. There were no problems with translation of the tool or validation or so on. But what we really looked into was the type of the questions asked in both. So when we looked at mental health, they asked direct mental health questions. So how is your levels of stress? Are there any emotional problems bothering you? And other very deep mental health issues. We know from a societal point of view that people really don't like talking about their mental health. It's still a taboo, and people really still don't think about it. So we presume that societal and social norms really impacted the results of the mental health outcomes in the survey. But when we looked at the well-being questions, it tied both the physical health and mental state, as you can imagine, to the question. So that gave us a more realistic assumption of what patients are seeing in their mental state, and that was basically more close to the average. I hope that answers your question. I want to close with this question by Dr. Reem. She says, impressive progress in the national journey, and this is a great question to close with. What are some lessons learned from the journey so far, and any specific insight from regional variations, so rural versus urban or others?
Yes, regarding like mental health? Or
regarding from the journey in primary care improvement.
Yes, actually, the lesson learned that we need to identify the gaps earlier on, and we need to include the necessary stakeholder. As I mentioned earlier, we have example of setting meetings and discussion with the Health Council of Healthcare Specialties, and also we need also to we have the contribution of the secondary and the tertiary level of care in the overall outcome of the overall patient health outcome. And these are major things to do. And the very prominent variation between the major areas and the remote areas were the flow of the patient and the expectation. We do have variation in the expectation of and the patterns of health seeking behavior from the remote and the central areas of the big cities like Riyadh, Jeddah, or Sharqiya. So, and when we talk about regions like Al Jof or Tabuk, they would even go and require healthcare services without appointment, and they do not expect that they need to be following with certain physicians over time. Instead, because of the demand on the healthcare services in the major cities, they would need to have an appointment in order to be, following with the physicians. The utilization of virtual care as well, it has been more prominent and more used in the major cities rather than the remote areas. The credibility of data, maybe the completeness of some of the major data or clinical data were even encountered more in the major cities rather than the small and the remote areas, where there's like a bit relaxed environment compared to the flow of patients in the major areas. So this would contribute to the credibility and the correctness of the documentation, and in turn the data reflected based on this documentation. So basically also there was like a variation between the capabilities, where major cities are covered by consultant board certified family physician, whereas some of the remote small areas are covered sometimes by GP. So we are very aware about these variation, and we look at it when we look at our operational KPIs, when we talk about access to care, when we talk about complaints like from 937. We do have like some elements and items that we look carefully at in order to differentiate between. For example, if I have like 100 complaints from a center of primary health care, I would not compare that to a center in one of the remote or small areas with 100 complaints. We look at it from this way. It has to be, in proportional to the demand and the needs and the capabilities.
Thank you. These are really insightful insights. And I thank you, Dr. Turkiya, and I thank our audience for being part of our webinar series and participating in our discussion today. We heard a lot about digital tools and digital literacy, care capabilities, and how that links to the model of care and transformation. And I hope this serves as a lesson to everyone about how our health system is performing. Thank you again for being part of our journey. We welcome you to attend next week's session, where we have international experts talk about the implementation of PREMs internationally and some of the results Saudi Arabia is different than others. Please register. Keep an eye on our LinkedIn posts for the registration link for next week's session. Thank you again, Dr. Turkiya, for being our guest today, and thank you to our audience. مع السلامة.
Thank you all. The pleasure is mine indeed. مع السلامة.